So Dr. Charles Grob is the professor of psychiatry at the Harbor UCLA Medical Center. I met him when I was a fellow still years ago. And he's a real pioneer in the studies, research on psychedelics before it was sexy. And he's going to present on the use of psilocybin at the end of life for fear of death and dying.
Okay, well, thank you, Helen, and thank you for inviting me to participate in this conference, and thank you for inviting me to present some of the research we've done at Harbor UCLA over the years, and why we've done it. You know, psychedelics were at one point the cutting edge of psychiatric research in the 1950s, the 1960s, and then the culture had a challenging reaction to the emergence of psychedelics, and research was entirely shut down. You know, they were perceived as a public health crisis, and it was just, I think, a little too threatening for the status quo, and it became silent for some years. Then in the from about the early 70s to the early 90s, there were no human studies with psychedelics. Then in the early 90s, we developed a phase 1 study to look at the range of effects of the drug MDMA in normal volunteers, and colleagues at the University of New Mexico and the University of Miami did similar studies looking at the range of effects in normal volunteers of dimethyltryptamine, or DMT, and ibogaine. And then there was very little activity with human research through the rest of the 90s. And then in the early 2000s, with my colleagues at the Hefter Research Institute, which is created to help facilitate and fund these kinds of studies, we decided that the study that really needed to be done was looking at the range of effects in individuals approaching the end of life, really following up on some very, very interesting research done in the 60s. So I'm going to talk with you today. Oh, here, this is grant support. The Hefter Research Institute provided the initial startup funding, and the Betsy Gordon Foundation helped us finish the study. And NIMH, I must admit, has not, since the 60s, actually funded a clinical study with psychedelics, but they did provide the GCRC inpatient research unit, which was indispensable for this study. So I acknowledge NIMH as well, and hopefully the funding decisions at NIH are going to soon be going through some changes. So this will be an overview of what we'll talk about this morning. It's very, I think, key in terms of understanding the range of effects of these compounds. You know, where do they come from? And in fact, they've been around for millennia, used by the native peoples in plant form who had intimate knowledge of the plants and their biological effects that grew in their geographic area. So understanding a little bit about ethnobotany, anthropology is important. We'll touch on the chemistry and the toxicity of particularly of psilocybin, which is the drug we work with. Psilocybin is the active alkaloid in hallucinogenic mushrooms. And then we'll look at some of the clinical research from the 50s and 60s, particularly focusing on some very important studies that utilize psychedelics, particularly LSD, with individuals with advanced cancer approaching the end of life who had overwhelming anxiety and depression. Take a look at some of the current research and the methodology and approval process that we went through at Harbor UCLA. We were the first group since the early 70s to actually do clinical psychedelic work in an approved context with individuals approaching the end of life. And then I'll tell you a little bit about what we found, and we'll follow up with maybe some of what the implications are. So here you can see that psilocybin grows in a variety of mushrooms. This right here is the one we're most familiar with, Psilocybe cubensis, but there are some interesting mushrooms that apart from cubensis that are worth looking at some point. They are widely distributed around the world. You can see particularly in the northwest U.S., northwest South America, and west, northern, and central Europe. And interestingly, their distribution around the world increases with human habitation. Where previously untrammeled areas are now being converted for homes, for businesses, is where mushrooms often, for some reason, start to emerge. I was at a conference some years ago where Paul Stamets, an ethnobotanist we'll talk about, showed some interesting slides of a wild crop of psilocybin mushrooms growing outside of a rural police station in Oregon. It was how they got there. I have no idea. So, and again, they seem to be found in disturbed areas, follow human expansion, and they follow where people congregate, and they have co-evolved with human in the presence of cattle, the domestication of cattle. They're coprophilic. They grow on cow dung. Here are some mushroom stones from ancient mushroom stones from Central America. So these little guys will keep us company this morning. So the use of various plant hallucinogens were used by native peoples around the world, particularly in the tropical regions where there's far greater diversity of plant life, and they were regarded with the highest esteem, within the cultural context. They were used for purposes of healing, divination. They reinforced the native belief systems, part of their spiritual process. They were never used for recreational purposes amongst native peoples prior to the arrival of Europeans. So that's a clear distinction from how they came to be used, in part when it hit our culture, and our culture was really taken, I think, by surprise and was not prepared back in the 60s. I think now that we're experiencing kind of a resurgence of interest in psychedelics, our culture is far more prepared. So Paul Stamets, the ethnomycologist from Oregon, says the course of human history has been dramatically affected by the use of psilocybin mushrooms and will continue to be for years to come. And I would agree with Paul on that. So when the Spaniards in particular arrived in the New World, they observed that the native peoples had their own idiosyncratic customs, which to the Spaniards were both bizarre and frightening. And they endeavored to repress the native use of various plant hallucinogens for their spiritual practices, for their healing practices. And a Spanish friar, Bernardino de Sahagún, says, recorded his observations, and he describes the use of mushrooms in ceremony. And he says when the effects of the mushrooms had left, they consulted among themselves and told one another what they had seen in the vision, because the actual vision, what they saw, was of great import to people from these indigenous cultures. In 1616, the Inquisition was applied to the New World with particular focus on the repression of plant hallucinogens and the use of the most serious penalties for anyone using such hallucinogens. And generally it was execution, sometimes very painful. The Spanish were also, they're very concerned not only with what they considered diabolic use of these plants by the native peoples, but they were worried that some of the Spanish settlers would be intrigued by the native custom and would be drawn to participate, and this was seen as as sacrilegious and fueled the harsh response to what they observed. And as a consequence, the use of these plants went deeply underground. So here we can see how these plants were depicted as very diabolical, as part of the devil's work. And another inquisitor of these idolatries that he observed, he says that when they take these compounds, these plants, it deprives them of their senses, it causes them to communicate with the devil, it deprives them of judgment, and it deceives them. So the antecedents of our own drug wars can be clearly seen hundreds of years ago. And the use of plant hallucinogens for sacramental purposes dates back thousands upon thousands of years. This is from 7,000 years ago. This is Kathleen Harrison's drawing based on a cave painting in the southern Algeria Tassili plain. And it's obviously a shamanic figure, and you can see these mushrooms projecting from the torso, from the appendages, and curiously, this figure wears a beehive, a bee-cone mask. And the significance of that is that in these prehistoric times, there was obviously no refrigeration, and so to preserve these compounds, they found honey. Keeping them in honey was a good preservative, and that explains the beehive mask. So for thousands of years, they were used for religious and medicinal purposes by widely diverse indigenous cultures around the world, and they influenced religion, philosophy, art, even our own modern civilization. The ancient Greek rites of Eleusis are now believed to have used a sacrament called the kakikion, which was created from a fungus, an ergot fungus that grows on rye, which is similar chemically to lysergic acid diethylamide, which is LSD. So even the ancient Greeks and the ancient Greek philosophers, had a profound respect for these compounds and had these remarkable experiences that they were allowed to experience on one occasion per year. And much of early Greek philosophy, which is a bedrock of modern Western civilization, conceivably comes from these rites of Eleusis. So the Spaniards came to the Americas where psychedelic mushrooms and other plant hallucinogens were widely used by the natives. The use of those compounds were suppressed. They went deeply underground, and for many observers, they ceased to exist. And by the 1950, by the mid-20th century, it was believed by many anthropologists of that day that hallucinogenic mushrooms had never existed, that they were either simply myth, not based on any factual reality, or they were confused with peyote, which was known to have hallucinogenic effects. But then in the early 50s, a amateur mycologist named R. Gordon Wasson, who had a fascination with mushrooms that he shared with his Russian-born wife, Valentina, heard from Robert Graves, the eminent English writer and scholar, that there was an extant mushroom cult in the highlands of central Mexico. So with that information in hand, Wasson organized an expedition to the Oaxaca region, Huautla de Jimenez, a very remote village, where he made the acquaintance of a curandera, a woman a native woman who was a healer and used mushrooms for her healing. Now it turns out that Wasson had some very prominent friends, including Henry Luce, who was publisher of Life magazine. And that, I imagine, is how this story got into Life magazine in 1957. I should also point out that this is not a mushroom elf, rather it's Bert Lahr, a Broadway actor of that time. So this was a very influential Life magazine article that really revealed to the modern world that indeed such plants with these remarkable range of effects did exist. So here is Wasson in his latter years with a stone from Central America depicting a mushroom. And here he is at the actual velada, or healing ceremony, that the Indian curandera Maria Sabina invited him to participate with. And here she gives him the mushroom. And Wasson had an extraordinary experience which he shared with the world through the vehicle of Life magazine, for better or for worse. And this actually directly led to Timothy Leary becoming aware of psychedelics. In a summer vacation in Cuernavaca in the summer of 1960, a friend of his, Frank Barron, who later became an eminent psychologist at UC Santa Cruz, told him about the psychedelic mushroom, and Barron had a contact with Maria Sabina and was able to obtain some mushrooms, which Leary took, and then the rest is, and I think that in many respects had an unfortunate impact on our culture and how psychedelics were handled. But this is Wasson's description, and he had this extraordinary peak experience of remarkable aesthetic encounter, and it had a deep spiritual undertone. But I also like to point out that not all mushroom or psychedelic experiences turn out well. Some become very, very frightening, and these drugs or even these medicines are not for everyone. They have their limitations, let's say. Here's a sketch from the 1870s in England. The English are known mycophobes, fearful of mushrooms. And but culinary mushrooms were very popular at that time, but there was a rash of inadvertent mushroom poisoning when mushroom pickers picked the wrong mushrooms, turned out to be psilocybin-containing mushrooms, and had very scary experiences. So the ill-prepared individual, perhaps the vulnerable individual, taking these compounds under adverse conditions can be in for a very, very scary experience. So set and setting are key, as is dose. So, okay, we'll look a little bit at the chemistry. Interestingly, many hallucinogens, including psilocybin, have remarkable structural similarity to the major central nervous system neurotransmitter serotonin, 5-hydroxytryptamine. Here it's 4-phosphoryloxy and N-dimethyltryptamine, but the basic indole nuclei is very similar. So in a sense, the human central nervous system has, through evolution, is wired to be remarkably receptive even to minute doses. LSD is active on a microgram dose. One of the most potent compounds known to man, and actually the discovery of the serotonin system in many respects is attributed to psychedelics. In the late 1950s, Daniel X. Friedman, who in his latter years became a professor emeritus at UCLA early on, he was the chairman at the University of Chicago. He did some interesting work where he injected is a preclinical study. He injected into, I believe it was monkeys that were the research lab. He injected radioisotope labeled LSD, and then took what primitive imaging pictures they had access to at that time, and found that certain areas of the brain lit up, and this became the whole basis for discoveries revolving around the serotonin neurotransmitter system. So the serotonergic system in and of itself was discovered through basic research with a hallucinogen. So psilocybin is in the tryptamine family, close resemblance to serotonin, and low generally physiological toxicity. Psychologically, as I mentioned, that's a whole other kettle of fish, and one has to go into this very cautious, careful, and take all the necessary safety precautions. but physiologically it's usually well tolerated. It's primarily active at the 5-HT2A and 2C, and also the 1A receptor sites. And the medium dose is what we were approved by FDA to work with, from 12 to 20 milligrams, produces a well-controlled altered state of consciousness that lasted for about 4 to 6 hours. And just here you just see the time course of psilocybin compared to the much longer time course of LSD. And similarly, you just see the plasma concentrate. It peaks, psilocybin peaks at about an hour and a half into the treatment session and comes down in a sustained manner till about 4, 5, 6 hours. It's at a very low level. And again, just shows you that urinary excretion is complete from 12 to 24 hours. So there are a variety of species of mushrooms. The one we know most about is cubensis. And these mushrooms have generally 3 active alkaloids: psilocybin, psilocin, and baeocystin. And you can see they're in different concentrations. What I find interesting is psilocybe azurescens and psilocybe cyanide. Well, mostly psilocybe azurescens, which contains a very high concentration of baeocystin, which has never been studied. So that's an area, I think, rich with potential for the future. To date, our own drug regulatory system really restricts us to working with single isolated alkaloids. Psilocybin is presumed to be the most active, but there's also baeocystin and psilocin, although psilocin is also an active metabolite of psilocybin. But I think there's future research to be done in that regard. The physiological toxicity, again, is relatively favorable, as you can see by this LD50 data. Now, here's something Paul Stamets. Now, I've used this slide for years, and I'm now having some second thoughts. He says you'd have to eat your own body weight in one sitting to adjust a toxic dose of psilocybin mushrooms. I'm not sure that's putting out the right message, and I think maybe for some individuals they can consume extremely high doses, and physiologically, psychologically, all bets are up. Physiologically, they might be able to handle it. However, since I made this slide, I've come across in the last few years a few accounts of sudden cardiac death in individuals with pre-existing cardiac vulnerabilities who were taking excessively high dosages, so, including a case just very recently. And I haven't seen the toxicology report, but it's presumed to be psilocybin mushroom. So one needs to, I think, instill a little more caution than some of the enthusiasts have over the years. Nevertheless, for the most part, it's well tolerated. Subjective effects of psilocybin: it stimulates affect, enhanced capacity for insight and introspection, sometimes compared to dream states or hypnagogic states, and it induces perceptual changes, including illusions, synesthesias, which is a very interesting phenomena of sensory perception shifting around. So you may see sound or smell color. It can occur spontaneously in rare individuals, but also under the influence of hallucinogens is often observed. And there are alterations of thought and time. The psychedelic peak experience is believed to be associated with positive outcome, and this is akin to a very powerful psychospiritual epiphany or mystical state, which conveys a sense of unity or oneness, transcends time and space, deeply felt positive mood, and a sense of awe and reverence. It also provides a powerful sense of meaning and insight. Ineffability. It's very difficult to sometimes put into words the experience. Paradoxicality. What you believe you're seeing may not actually be what you think. And transiency. It's so profound and timeless in the moment, but then it's over and it's as if it was just a fleeting moment in time. Bill Richards, who's one of the co-authors of this psychedelic peak experience, very interesting individual. He not only was involved with the Spring Grove, Maryland psychedelic research program in the 60s, in the 2000s, he became the research psychologist for the Johns Hopkins psychedelic program. So Bill is about the only one still around who is still active and who spans these generations of psychedelic research. So two, I think, very important individuals in this field. Albert Hofmann is known for being the discoverer, the serendipitous discovery of LSD in 1943. What most people don't realize is that when Wasson came back from South America, he had collected samples of the mushroom. He'd sent them to the leading medicinal chemists around the world, and none of them could kind of break the code. None of them could isolate the active alkaloid until Albert Hofmann took a crack at it, and he was the first to isolate psilocybin from the mushrooms. Incidentally, Hofmann lived to 102. For his 100th birthday, there was a big gathering in Basel. I attended a big conference honoring Hofmann, and he in front of 1,000 people, this huge auditorium, Hofmann, with 2 hip replacements and a knee replacement, got up before the audience and gave a brilliant extemporaneous talk for an hour. And I just kept thinking, if he's any example of the long-term effects, who knows? Okay, so the other important figure, sometimes not recognized, is Aldous Huxley, the renowned English writer who wrote such great books as Brave New World, and his last book, Island, published after his death, which really reflects how psychedelics might be optimally used out in the world. Now, Huxley, in the last 10 years of his life, was fascinated with psychedelics. He was introduced to psychedelics in the early 50s by Humphrey Osmond, one of the leading researchers of that day, who came to LA for the APA and had arranged to meet Huxley, and Huxley had this profound experience that he thought would have great import to the fate of man. Remember, this is not too long after World War II. The world, particularly Europeans, were still reeling from the horrible havoc and destruction, and there was a lot of, and the nuclear bomb had been invented. There was a lot of concern about the perpetuation of life on this earth. Huxley felt these drugs had remarkable potential to make the world a healthier, safer place, and his model was to introduce it to the leaders of society, not taking into account that others like Tim Leary had a different idea, and so the Huxley model was shunted aside. The Leary model took hold, and it grew, and then it collapsed. But Huxley had this belief that psychedelics could help facilitate the transition from life into death of those approaching the end. And he not only talked the talk, and he did talk a good talk, he also walked the walk. As he was dying of cancer of the throat, he arranged with his doctor and his wife Laura to be administered when he gave a signal. He couldn't speak, but they set up a signal. He arranged to be administered an injection of 100 micrograms of LSD. And as he lay dying, he gave the signal. The doctor injected him, and for the next few hours, according to Laura, who was actually a friend of mine, for maybe the last 20 years of her life, I got to know her quite well. She often described this experience. Aldous was seemingly very much at peace. There was no trip report. He couldn't talk. He didn't try to communicate, but he seemed at peace and slowly, quietly exited. She sat with him for a while, along with the doctor, and then she decided, my house is full of people, relatives and friends who were keeping the vigil as Aldous lay dying. So she went out to inform them that Aldous had passed away, and she went out to the big living room area. No one was there. The house was empty, or so it seemed. So she walked around the house looking for this group of people that were holding vigil, and there she found them finally in a little room off the kitchen, which was the TV room, and they were crowded around the TV set, and she thought to herself, they call themselves great friends of Aldous, and here they are watching television as he dies. So she was going to reprimand them. She was going to really tell them off. But before she did so, she wanted to see, what is it that they're watching? So she leans forward and she sees that what they're watching are the first reports out of Dallas that John Kennedy had been assassinated. So on this virtually the same moment in time, we had two major figures in the history of our culture pass on, Huxley and John Kennedy. So make of that what you will. Interesting serendipity. So Lester Grinspoon and his colleague back in the late 70s, after the first generation of psychedelic research had subsided, did a thorough review and found that there had been over 1,000 clinical papers published in the professional literature describing the experiences of over 40,000 people treated with psychedelics. And these are some of the applications. Some of the most difficult to treat psychiatric conditions appeared to be amenable to this very, very novel treatment approach. The data on alcoholism was really remarkable, and it's very easy to test the efficacy of a treatment for alcoholism. You either continue to drink or you don't, and they found a very, very sustained in many subjects, sobriety. Osmond did a retrospective of some work he did in Canada and found that about a third of his alcoholic patients, after just one treatment session, relapsed quickly. A third maintained sobriety for a period of time, then relapsed. But if the final third had maintained sobriety for some years, and he found that while all three groups may have had powerful insight or powerful visionary, aesthetic kind of experience, it was the third group that did the best that reported they had what sounded like a psycho-spiritual epiphany, a mystical mimetic level experience, which seemed to be predictive of their positive outcome. So other conditions, psychosomatic disorder, chronic PTSD, there's some modern work starting in South Carolina using an MDMA treatment model for chronic PTSD that is showing remarkable efficacy. OCD, again, one of our notoriously difficult areas to treat. Some work at both University of Arizona and Yale in recent years has replicated this, and then antisocial behavior. Autism, I did a study with my colleague Alicia Danforth at Harbor UCLA several years ago where we had permission to use an MDMA treatment model for adults on the autism spectrum who had severe social anxiety, targeting the social anxiety. It was a placebo-controlled study. We found a very strong drug effect. It was published in Psychopharmacology this past year, so we found good data. And then finally, the existential anxiety and terminal cancer, which is really the gist of what I want to talk about for the rest. So as everyone here knows, the process of dying can be extraordinarily challenging. It's associated with high levels of depression, anxiety. People can become quite isolated. There's a great deal of physical and emotional suffering. It also can infect those around them, caretakers, family caretakers, professional caretakers, nursing and medical staff. It can be a very, very challenging experience. Now, the field of oncology has really made great strides in prolonging life, increasing the quantity of days, but there's still work to be done on how to facilitate improvement of quality of life during the remaining time. So the first investigator to take a look at this phenomenon was Eric Cast, an internist in Chicago. He was a pain specialist, and he heard in the early 60s about a new novel drug manufactured by Sandoz in Basel, Switzerland, and he decided he wanted to look at the effect of LSD with his chronic pain patients. And in those days, all you needed to do was write away to Sandoz, say, "Hi, I'm Dr. So-and-so. This is what I want to look at," and couple weeks later, you'll have a box containing the psychedelic drug in the mail. There were no real restriction, minimal restrictions and regulations in the early 60s. So Cass treated a large number of advanced cancer patients with pain. He initially just gave it to him and said, right here, take this drug, and when I come by in my rounds tomorrow, tell me what it did. So he quickly learned that's not how you administer a psychedelic. So he did his homework and then created a far more appropriate structure. And he found, when he analyzed his data, that he had excellent analgesia compared to conventional narcotic drugs for pain, and that even one experience could noticeably reduce pain for some weeks. He attributed it to an attenuation of anticipation. That chronic pain patients are not only dealing with the pain of the moment, they're also anticipating the pain that will most assuredly come in successive moments and hours and days, because that's been their experience, and somehow it breaks through that cycle and it attenuates, lessens the anticipation. He also found positive effects on mood, on sleep, and on fear of death. Then Walter Pahnke, it was he had a Doctor of Divinity, and then he went to Harvard Medical School and trained at Harvard to become a psychiatrist. And he decided to work, he wanted to work with terminal cancer patients, and he was very interested in looking at whether or not a mystical experience might be predictive of outcome. So he found that of his patients, about a third improved dramatically, a third moderately, and a third evidenced no change. And he found that the most dramatic therapeutic effects came in the wake of a mystical experience, a profound psychospiritual epiphany. And there was a decrease in fear, anxiety, depression, and sometimes lessened need for narcotic pain meds, which was a finding also of Cass. After the treatment, his chronic pain patients needed less of the narcotic, and an increase here in serenity, peace, calmness, decreased fear of death. Stanislav Grof was a Czech psychiatrist. He started off as a medical student at Charles Medical School in Prague in the early 50s, and he later emigrated during the Prague Spring to the U.S., established himself in Baltimore, at University of Maryland, and at Spring Grove, Maryland Psychiatric Research Center. And Grof probably treated more patients in an approved context with psychedelics than anyone in history, and he's got a wealth of experience. He's been a prolific writer. He's got some excellent books that I'd recommend. One of his first books was Human Encounter with Death, which details his experience at Spring Grove treating terminal cancer patients. He treated a total of 60 patients. He found that about a third, or about 30%, dramatically improved, 40% moderately improved, 20% unchanged, and a small percent with some decrement did post-treatment ratings. And as his colleague, and he found changes in attitude and increased acceptance of death and improved emotional status. And I should also have it here. And like Pahnke, he found that the mystical experience was predictive of the therapeutic outcome. So this is all very interesting, I think, findings. So Grof's study at Spring Grove was shut down. Most studies ended in the late 60s because of the cultural reaction, perception of a public mental health crisis, the felt need for authorities to put a lid on this. They were particularly concerned about young people who were seemingly taking these compounds in uncontrolled contexts. There was also the identification of psychedelics with a politically active counterculture, which was deemed as needing to have some limits put on that too. So research went to rest for about 20 years, but then reemerged in the early 90s and has really picked up in the 2000s. About a year ago, a year and a half ago, a very popular writer named Michael Pollan published a book on psychedelics called, I think, Changing Our Minds. And Pollan is a celebrity in his own right. And this book really caught fire and became a #1 New York Times bestseller for some weeks. And before you know it, people who thought this was a completely off-the-board issue are rethinking and wanting to get involved. Now, I think what Pollan oversold is how active the research is right now, because I get calls all the time from people who are saying, where can I sign up? And I got to tell them, well, we're not really there yet, so maybe in a couple of years, but not yet. Although there is some active work going on we could talk about. So some really good work just looking at basic neuroscience. What are the effects on the brain by a group in Zurich at the Berkholtzy Clinic, which is where, incidentally, Carl Jung worked. Franz Vollenweider is the research team leader. They've been very productive since the 90s. And here's his, looking at his PET studies. So here you could see the baseline brain. And remember Nancy Reagan and the war on drugs? And this is your brain on, this is actually your brain on drugs. Forget about the fried eggs. This is really what's going on. So you could see where it lights up, glucose metabolism lighting up in the frontal-lateral, frontal-medial areas, the anterior cingulate, some temporal areas. So this is actually your brain on drugs. So the neuroscience has really advanced. Here's some work from Francisco Moreno at the University of Arizona looking at the treatment of refractory patients with obsessive-compulsive disorder. And he found acute, robust, positive effects. And there's now a follow-up study being organized at Yale, which hopefully will give us some interesting data. Now, let me just mention, curiously, Johns Hopkins has become the leading center for psychedelic research around, at least in this country, and I'm delighted because I come from Johns Hopkins. I not only trained there and was on faculty there, but I was born there. My father and mother were doctor and nurse, so I am, to some degree, I embody Johns Hopkins. But Roland Griffiths is the team leader there, and he's done some great work following up on Grob and Pankey's studies in the 60s, looking at whether or not you can reliably facilitate a mystical level experience. If you adequately control setting, do your proper screening, make sure you're going to treat people who can handle this experience. And what Griffiths has demonstrated is when you optimize conditions, you can reliably induce this kind of mystico-mimetic level experience. And if you put that together with the Grob and Pankey findings that the best clinical outcomes are with those people who have this mystical, spiritual kind of experience, I think this is a very important information, at least in terms of a psychological mechanism. Vollenweider in Switzerland can talk about a neurobiological mechanism, that it's the 5-HT2A, 2C receptors that seem to be the what causes the psychedelic effect. And now Griffiths finds under optimal conditions there is a potential for a profound mystical level experience which can be predictive of a therapeutic outcome. So in the early 2000s, I went to FDA with a proposal, and to my surprise, they approved it. Yeah. So they were ready to allow this work to resume. We were approved to treat 12 subjects with metastatic cancer who had high levels of anxiety. These were adults, and yeah. So there were, the necessary exclusion criteria. We ruled out individuals with primary brain tumors or uncontrolled blood pressure, severe cardiovascular illness, or serious history of psychiatric illness. And it wasn't just bring them in and give them the drug. We did a lot of preparatory work with them. We did screening first and then preparing them for the experience. We use a double-blind placebo-controlled methodology. Niacin was our active placebo. We had a moderate dose level of psilocybin approved by the FDA. We actually asked for a higher dose. They said, no one has looked at this for decades. You've got a vulnerable population. Use a more moderate dose. We agreed on a 0.2 milligram per kilogram. We used our NIMH-funded GCRC setting, and we did a great deal of follow-up evaluation and integration going out for 6 months. So we took, where we did it on Harbor UCLA. Did anyone here know Harbor UCLA? It's not like the Ronald Reagan Medical Center. It's more bare bones. But so we took a conventional room, a single room, that fortunately had 2 heavy doors insulating out hall noise, which was really important. And my co-investigator, Alicia, had a great touch for making the drab look beautiful. And so we did this. We brought in a lot of flowers and asked the subjects to bring in important photographs of their childhood, of their children, of their own parents, and whatever else, meaningful objects. And Alicia and I would sit with them for the whole day. We did our treatments on Saturdays because I needed a whole day. I couldn't be paged out because I have a job there, and then Sunday we came back in for the integration session. Patients spent Friday night, and if they didn't have a driver, they spent Saturday night as well in the hospital. So we did, mood rating scales, anxiety scales, kind of phenomenologic scales, pain readings, quality of life scales. We went out to six months. So I'm often asked, why didn't you work with LSD, since there's so much more data from the 60s on LSD? And psilocybin only had a modest number of studies. The reason why we chose psilocybin over LSD is psilocybin is gentler, it's less intense. This experience of shorter duration, 4 to 6 hours, as opposed to LSD's 8 to 12 hours. It has a stronger visual component. Moods are more likely to be positive as opposed to dysphoric. There's less likelihood of severe anxiety or panic, less likelihood of paranoia. But most important of all, I felt there had been less negative publicity. If we were going to do an LSD study, everyone already has their mind made up for that it's good or it's horrible about LSD. It was likely to create a lot of negative publicity we did not want. So and most people had not, at that point, had not even heard of psilocybin. We obviously explained to all the prospective subjects. They definitely knew what it was by the time they were done talking with us, but it didn't have the cultural, sociological reputation of LSD, which we felt problematic. And psilocybin we felt would be more likely to help us. We could recruit better for that. So we had to go through a number of regulatory hurdles. That process actually took us a couple of years. Every time we sent in a protocol, it got critiqued. We had to rewrite it. But at the end of the day, I think we ended up with a better protocol. We had very collegial relationships with the regulatory agencies, and we listened to their advisement, and we modified the protocol accordingly. So we had to go through FDA, DEA. California has its own in-state kind of FDA for Schedule I drugs, the Research Advisory Panel of California, and then our hospital IRB and Research Committee. So we had 12 subjects ranging in age from the mid-30s to late 50s. Curiously, 11 of the 12 were women. There was only one man. I have no explanation for this. Maybe women are more courageous. I don't know. We certainly had men look into the study, but for one reason or another, they couldn't participate. They were perhaps too ill. The logistics of getting there were too problematic. And I had one guy who we had set up a screening appointment. He didn't show up. Then a few hours later, I got a voicemail from him saying, I drove over to your hospital today. I couldn't find a parking spot. I didn't like the vibes at a hospital, so I left. It's okay. It's not for everyone. So this is just a sense of kind of people we're working with. We had, I think, 4 with colorectal cancer. No, 4 with breast cancer, 3 with colon cancer. 2 with, I think, ovarian, 1 peritoneal, 1 salivary cancer, and 1 multiple myeloma. By definition, they had to have approximately 6-month life expectancy. Most of them, not all of them, but most of them exceeded that. Although we were not out to look at any effects on the cancer in and of itself. So vital signs remained normal, just a very modest elevation in heart rate. Blood pressure with this moderate dose was also quite just a modest elevation. See, diastolic, only went up into the 70s. So we didn't really have any problems at all maintaining good vital signs. Some of the high dose studies, which followed in our wake, did have a little more challenges with vital signs. But this dose we found was easy to work with and did not seemingly cause any medical issues, which is first and foremost, or above and beyond everything else. We don't want to cause any harm. So we had Holter monitors looking at cardiac tracings for the full time they were in the hospital, and we had the head of cardiology at that time, Chuck McKay, analyze the data, and he found that both people on placebo and psilocybin did have a fair number of some rhythm anomalies, but nothing significantly stood out as one versus the other. So he felt we were not getting appreciable effects on cardiac rhythm. Here we have the altered states of consciousness phenomenologic scale. This is oceanic boundlessness, and so some visual restructuring, auditory effects, altered. This is ego dissolution. Just see compared to placebo. And here you can just a lot of derealization, depersonalization, altered sense of time, positive mood, et cetera, et cetera. And initially, there was no evident effects on mood, but if you look at, and this was, the study was set up such that people were randomized, and it was all blind, so they were randomized to get either psilocybin or placebo first, and then a few weeks later, they had the opposite condition. So everybody, we felt ethically bound that people were at this point in life, they were excited about being involved in a study. We didn't want to deprive anyone of the active experience. Not maybe the ideal research methodology, but we felt under the circumstances is what we need to do. So everyone functioned as their own control. So in the 2 weeks after the treatment, the first treatment, no discernible difference between placebo and psilocybin. However, when you just look at everyone then got psilocybin, and if you looked at the 6-month point after psilocybin, you did find a noticeable improvement in mood that even reached significant proportions. Looking at the STAI Trait anxiety inventory, we found nothing to report of meaning with the state, which is how you see yourself in the moment. But if you look at trait, which is how you identify your level of anxiety over the previous couple of weeks, we did find significant amelioration of anxiety at a couple of time points and a sustained drop in anxiety. So we were, even with a modest number of subjects, we were pleased with this outcome. So we published in the Archives of General Psychiatry, later renamed JAMA Psychiatry. At that time, it was the #1 impact journal in the field. So we felt if it could gain acceptance into the archives, it really must reflect a growing acceptance within the field. And that really is the case, as we see lately, more and more positive statements coming from some of the leaders in the field and even the regulatory agencies, that they're ready to support research in this area in a more proactive manner. Since we did our study, 2 other studies were conducted, basically looking at cancer populations. The NYU study got permission for a higher dose. They came after us. They made the argument that since we had demonstrated good safety and efficacy with a moderate dose, they asked for permission for a higher dose. They got permission to use a 0.3 mg per kg dosing model. We gave them our protocol. They basically followed our protocol, adding some additional instruments, and they got very good results. And also the study at Johns Hopkins, which did not treat advanced cancer, rather cancer of any stage, but did have permission for the higher dose model, also had, these were published I think in 2016, very good results. There had been a plan to initiate a multi-site trial with this patient population using psilocybin, but for reasons I'll explain in a minute, that has not happened. But over the last year or so, I've been talking a lot with Ira Byock, who I know was here yesterday. I don't know if he mentioned this topic, but he and I and Tony Bastos from NYU have been putting together a protocol for a prospective multi-site trial in the palliative care setting. So that's kind of the current focus. We're putting together a protocol, and we will be looking, and we are looking for funding. So yeah, if you have a spare, 100K and change lying around, we could use it. So Sidney Cohen, who was a UCLA physician back in the 50s, was one of the leading investigators of psychedelics, later became quite disillusioned because of the cultural reaction to it. Still, he did some very important work, and he worked with people who were close to death, and from his work, he came up with the insight that death must become a more human experience to preserve the dignity of death and prevent the living from abandoning or distancing themselves from the dying is one of the great dilemmas of modern medicine. And Cohen, as well as Pankey, as well as Grob, as well as the modern investigators, would concur with Cohen's sense of the potential value of a well-constructed psychedelic treatment model for individuals approaching the end of life who are grappling with existential dilemma. And these compounds seem to instill a sense of meaning and purpose to individuals' remaining time. And I think that's where their ultimate value rests. This is our group. This is Alicia Danforth, who was my co-investigator, was a very, very important. Pre Chopra was a resident, helped us with our playlist. So he sat in for a few patients. These are the other collaborators who helped us with one aspect of the study or the other. A nice picture of a mushroom. And just a few final thoughts here. So I think it's really important to value and understand what the ancient peoples can teach us about these compounds. Keep in mind, for millennia, they had access to these powerful hallucinogenic plants. They knew how to utilize them optimally. Let's understand how they use them, why they use them, how they contain them, how they optimize safety and outcome. So I think there's a lot to be learned from the ancients, and also we have to, on some level, pay back. There's an appropriation of somebody else's culture here, or culture, what was valued to other cultures. They kept the torch aloft for an enormous amount of time when these compounds were condemned very harshly for thousands of years even. And I think we need to honor the native peoples for what they have provided for us. We have to, for future studies, we need to optimize safety. I really think it's going to come down to whether we could establish and maintain strong safety parameters. If cases start to go off the rail, if you have unethical, cavalier investigators or facilitators, you increase the likelihood of adverse outcomes. That's going to be a huge problem, and it may, as happened in the 60s, cause the field to come to an abrupt halt again. Ethical standards are essential. These compounds can dissolve boundaries, so you need investigators who have good boundaries themselves, who will not take advantage of someone whose defenses have evaporated for the time period. I'm a believer also that there should be co-facilitators for this kind of work, and there should be a male-female dyad. Maybe there are exceptions to that, but I think all in all that's a safer, more effective model. We need to understand what's going on out in the world. You know, how are vulnerable people, let's say young people, going to react when they hear that psychedelics are perhaps becoming more accepted within mainstream medicine and psychiatry, and we need to be very cognizant of how the recreational model is problematic and can cause serious problems to some vulnerable people. There needs to be greater diversity. You know, if you go to psychedelic science conferences, honestly, it's a bunch of white guys, and there's more to the world than that. So, and there needs to be more women in leadership, I must say, and that's, I think, a challenge for the generations coming up. The regulatory system. When I first started this journey in the early 90s, I was rather intimidated by. I heard some scary stories by people who had gone before, but I found the people at FDA, DEA, the state system, to be really helpful and very collegial, and I have nothing but good things to say about them. So it's feasible. You just have to be very patient, not be reactive if they critique your protocol. Address it. You know, you don't have to necessarily make the change, but you need to provide a cogent argument why you're not going to accept that change. And then the funding option. This is kind of a change here. We conducted this research on a shoestring. You know, a lot of my time and Alicia's time were pro bono, but they're very costly. They can be very costly studies, and they also, as it's gaining greater interest through society and greater acceptance, and there's this sense that it's going to be incorporated, some high-powered entrepreneurs want to get in and basically establish businesses that'll provide this treatment, and I think this is problematic. You got psychedelics and you got capitalism. I just don't think they work together. I think some kind of socialistic model might make more sense for at least for this. But when big pharma wants to get involved, or people from big pharma, this is problematic. You're getting some very conservative, very well-known individuals making big donations to these new companies that are cropping up. There's a company in Europe named Compass that wants to establish a series of clinics across Europe and the U.S. where they're going to test out whether psilocybin can treat depression. I have some concerns about the safety parameters. That's something for another day. But what I found shocking was that it's a for-profit company, and one of their big investigators, to the tune of millions, is Peter Thiel, the founder of PayPal, who has, I don't know him, I know very little about him, but I understand he's got a rather unseemly reputation for some of his behaviors. The organization called MAPS, which some people may be aware of, they funded the MDMA studies I did in the early 90s and more recently. They accepted $1 million from Rebecca Mercer of the Mercer Foundation, active Trump supporters, active Breitbart, Bannon supporters. It's just something to consider. These are ancient practices which we've been working, our groups, and from the 60s, just to try to establish acceptability, to pursue what their range of potential effects are. It would be a shame if it just turned out to be another money-making venture. So I think that these are going to be issues that's going to be focused on in the future. That's my study, and my. So,
Thank you.
There you go.
Let me just ask you, what is it about mystical experiences that predicted positive outcomes? What aspect of is it that the other side is not that scary?
I think it was more this sense of that there's something beyond, that it doesn't just all end right here.
Okay, thank you.
Hi, my name is Joanna. I'm a hospice nurse. I do have a question, but I just want to preface it with that I met Alicia in 2008 through my friend who was number 12
Oh,
through Lou. He was a really good friend
right.
of mine, and I know he got a lot out of being a participant in that study, so thank you. And I saw you at MAPS in 2010.
Okay.
My question is, if you know anything about if there have been studies done on the use of THC in helping people with terminal cancer, on hospice, in addressing anxiety, pain, sleep, and if there's any dosages or any studies that have been done on efficacy.
Yeah, I know there's some interest in developing such studies. I mean, that's not where my expertise is. I don't recall seeing one. But but I think given the incredible interest in medical marijuana, this would be a logical area to develop some rigorous studies.
A lot of these herbs and psychoactive ingredients were used in ceremony, and so the person was prepared for what was to come, or they would address in advance what experience they wanted to have through it. So how do you include that? Because it's such an essential part of the actual substance use.
Yeah, no, Sarah, you're absolutely right. People didn't take these compounds by themselves. It was always within a ceremonial context. I've also done a lot of research of ayahuasca down in Brazil among the syncretic religions, and there I really got that sense of how important ceremony was. But what's also important, so it's not a group process with our patients, but we do talk quite a bit ahead of time during the preparatory phase with what is your intention. I think this is always a very essential thing when, kind of establishing someone's mental set about having this experience. What do you hope to get out of this? Is it for purposes of healing, insight, working through, dilemmas, trying to find answers to questions, just going in with some vague, intention of I want to have a wild experience is a recipe for a problem.
But part of the ceremony was also protection.
Right. Right. Yeah. No, the ceremony that provides really a protective structure to help individuals contain their experience. So, I think. I learned a lot about, I studied with Ralph Metzner. I don't know if you know Ralph Metzner. He was actually a student of Leary's, but went on to do a lot of very original work, very prolific, has a lot of good material out there. And he kind of taught me the value of the structure as the collective container to help individuals process their material without incurring undue risk or feeling out of control.
Here, is there any reason why you combine niacin to this drug, psilocybin?
So what niacin was our active placebo. So you got either niacin or psilocybin, and then a few weeks later you got the one you didn't get. So why we chose niacin as a placebo, we wanted individuals to feel that they're on a drug, and niacin will give you usually kind of a slight buzzing sensation, you're kind of a little prickly feeling in your skin. I wouldn't use niacin again because I did have two subjects who had very severe niacin reactions. They had a severe flushing, a lot of itching. They felt very uncomfortable. I felt very bad. In fact, those are my two most severe adverse events in the whole study. People, when they took psilocybin, tolerated it better than niacin. So that was a finding. And for my subsequent study, I used cornstarch, just a completely inactive placebo, because I didn't. And one of the studies, a Hopkins study, used what they called a subthreshold dose of psilocybin. The problem there, and I think it was a problem, created a problem with their data, was that even a subthreshold dose of a psychedelic may not really be subthreshold. We have this interest in microdosing. And this is a lot of anecdotal accounts that microdosing can be therapeutic. There are no controlled studies to say whether it is or not, but at least we get a sense from microdosing that even at what is presumed to be a subthreshold dose, something may be happening, on a psychedelic level. So is there a mic?
Whoever has mic.
You've got the mic.
Hi.
Oh.
Hi. I have a question about, you recommended the dyad for sitting, and I wonder if while the client is on the medicine, is there an interaction between the sitters and the client?
Usually there's, with psilocybin, it's put the eye mask on, put the headphones on. We've got pre-selected music. We've done a lot of preparation. We do additional preparation before they ingest the medicine. I brought into the session a little ritual I learned with Ralph Metzner about honestly calling in the spirits of the four directions, upper realms, lower realms. Doesn't quite go along with kind of a rigorous reductionistic medical setting. Nevertheless, I thought it really helped just ground people, allow them to be more receptive. And what's the rest of the question?
Is there an interaction?
Yeah, so mostly Alicia and I would sit there and just be quiet. We wouldn't talk with one another. We wouldn't read. We would just sit there and meditate, reflect. Every hour we checked in, and I asked them how they're doing. We got a blood pressure. And if they wanted at any point talk to us about what was going on, they could just sit up, take the shades off, the headphones off, and we'd be right there to talk with them. But I would encourage them often to just go deeply back into the experience. There'll be plenty of time after the 6-hour point for us to process and start the integration process. But, you know, sometimes, there was one occasion where we had a woman who seemed kind of agitated. She was squirming and just seemed very tense. And I thought she needed some touch. I didn't think it should be from me. I didn't think that would be appropriate. So I whispered to Alicia, sit on the edge of the bed, hold her hand. Just hold her hand. And that really helped to ground her. I can tell you another story about somebody else's study where there were two male co-facilitators. And they had a woman who I believe, from what I heard about her, had a history of early abuse. And she was getting agitated, so the two men sat on the edge of the couch or the bed, and she really panicked at that point. So that's why you never know what you're going to have. Sometimes the subject will resonate or need reassurance from the female, sometimes from the male. So I think it's important to have that male-female dyad, although some of my colleagues argue with me on that. Yeah.
Hi, thank you so much for your wonderful study. I wanted to ask if, I'm halfway through Michael Pollan's book, and if you also tried this yourself, because he does mention that as part of the study.
I've been talking about this for 30 years. I rarely get asked that. Oh, well, what the hell, you know. I'm an old guy now. So, yeah, obviously. I grew up in the 60s. How could you miss it? I went to college in 68. But I also feel there's actually a debate. Should facilitators have their own first-hand experience? And my thought is it's going to be awfully hard to help someone navigate a very strange, unusual, novel terrain if you've never been there yourself. So there are actually efforts underway working with FDA for some of the larger scale studies to get permission to provide teaching treatment sessions for the facilitators. So I think it's of course you got to screen your facilitators as well, but I think it will help optimize safety of that session. If someone does get very anxious, have some reality testing issues, if you've been there yourself, you'll be better able to help that person stay grounded and reorient them.
Okay, last question, and then we'll break for lunch.
Thank you so much. It's so exciting, this area of research. I wondered if you could speak to how specifically you worked with participants in your study in understanding with them their intention related to their terminal cancer, and then what you did for your integrative sessions afterwards.
Yeah. So what I found was of most value to our subjects was that it kind of reinfused them with a sense of meaning and purpose. It kind of helped them address the existential crisis. help them really address all these sense of self changes they had gone through. So so having meaning and purpose was kind of an outcome, and this was something we processed in our integrative sessions. Really, primarily these kind of existential level questions. And our subjects did really well. We stayed in, at this point, everyone has passed on. The formal follow-up was 6 months. A couple people passed on before that, but and with some of them, we even maintained informal contact for the duration of their lives. And they continued to reflect back that they found this experience, it was a one-time event, of significant value to helping them cope and really get a sense of, internalizing that this was happening and come to terms with it and optimize the quality of the time they had left. They reflected back to us that their relationship with close family, with friends had blossomed. A lot of these people had become increasingly isolated, embittered, overwhelmed with anxiety prior, and afterwards they felt they could re-engage to a limited degree, but still to the degree they could physically handle it, re-engage the world, at least of those people they were close to. So it kind of revivified important relationships.
Okay, excellent. Thank you so much. Very enlightening.